Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
It's a great honor for me to introduce our guest today, Dr. John Cranham. Dr. Cranham has an aesthetic-oriented practice in Chesapeake, Virginia, and is an honors graduate of the Medical College of Virginia in 1988. He is an internationally recognized speaker of Aesthetic Principles in Dentistry, Contemporary Occlusal Concepts, Treatment Planning, Restoration Selection, Digital Photography, Laboratory Communication, and Fulfillment in Dentistry. He's an active member of numerous professional organizations, including the American Dental Association, the American Academy of Cosmetic Dentistry, and the American Academy of Fixed Prosthodontics, and the American Equilibration Society. Dr. Cranham is also a co-chair of Advanstar Dental Media CE Advisory Board and is the clinical director of the Dawson Academy, where he is involved with many of the lectures and hands-on courses with the curriculum. So, John, it's a great pleasure to have you on the show. The podcast is called Dental Implant Practices, so I would like to lead in with you just kind of telling me about what you're doing right now in your practice and specifically at the Dawson Academy right now.
Sure. So, yeah, my practice is pretty balanced between doing procedures 3 days a week and teaching. And so currently probably a third of my time, roughly 65, 70 days a year, I'm teaching. And then 2/3 of the time I'm still actively doing dentistry. Most of my cases, or most things I'm doing, is focused more on solving more complex problems, whether it's aesthetics or implant-related type procedures, and then, of course, TMJ and occlusion, wear and things like that, occlusally related type things. Dawson Academy is exciting times right now. We've sort of expanded what we do quite a bit. What was once a St. Petersburg-based type teaching institute where everybody came to Florida, we're now offering what we do in multiple locations in the U.S. and then 5 international locations as well. So, a lot of what I do at the Academy is sort of the keeper of the curriculum, help us obviously design it, standardize it, and involved in the larger hotel courses, and then help pick and train the people to do the hands-on as well as participate in that. So it's busy, but it's an exciting time to be in something that's been around a very long time, but continues to evolve with our rapidly changing profession.
Sure. Yeah, that's great. I know, 3 days of clinical practice is probably enough for you, along with all the teaching you're doing. But I've definitely taken most of the classes at the Dawson Academy, and I know there's a lot of balance in the teaching with that. Tell me about how you're specifically integrating implants into your personal practice.
Well, I just think that there isn't any going around the fact that it is the fastest growing segment of dentistry right now. It's become such a normal part of what we do. It's strange, but 20 years ago, everything was Mr. the Tooth. You talked about a 3-tooth bridge, and I think the science really supports the fact that an implant solution, most of the time, not all the time, but most of the time, is going to be the right option. And of course, I think the other thing that's driving it is the baby boomers, unlike their parents, who sort of expected to lose their teeth and were, okay with having a denture. I just don't think it's as acceptable as it once was. And so, a lot of my cases now that are, whether it's, catching something that's a little bit early where there's some missing teeth, or full reconstructions where people are losing their teeth, involve implants. I think what's cool about it, though, is how well my training with Dr. Dawson, our approach to diagnosis and treatment planning, and really visualizing where teeth go from an aesthetic and functional perspective, that process of doing the case in our mind and then wax first, works so well with implants because, dental implants are a prosthetically driven discipline. So if we figure out where the tooth goes first and then relate that tooth position to the cone beam, well, we're going to have a much better chance of having a correct surgical guide made so that the implant is in the right spot for us to be able to make a nice restoration, whether it's a single crown, a bridge, or, a full, on immediate load type, all on 4, all on 5 type hybrid or full zirconia type restoration. So when I started really coming back around to implants, and maybe we can talk about that in a little bit, but when I really started coming back around to it, it was interesting that how well it fit to just simply add that treatment option to the complex planning that I was already doing. And so it just now feels like it's just another tool that we have in the toolbox to help patients get stable and healthy.
Yeah, I definitely agree with you. I think it's a prosthetic solution that you start with the end in mind, and the process just happens to have a surgical component to it, regardless who's doing that surgery, whether that's referred out to a specialist or the general dentist that's treating. But it definitely needs to be thought about prosthetically first and balanced in that master plan, and then work backwards into where do we place the implant or implants and how many. And definitely the cone beam and treatment planning allows that process to happen smoother and with greater success nowadays. So
yeah, and I agree with you. I mean, the other part of it for me is I took some surgical training back in the 90s. At that time, a guy named Tom Ford in Orlando, and then Mike Picos, everybody knows Dr. Picos, we're doing some classes together. And I went through the cross and the surgical training. And it was back then, it was Corven, and they were doing some Calcitech courses, I think. But, I went through all that. So I learned the cross and where that was then, and then I learned some of the surgery. But I maybe did 30 or 35 implants and just didn't like it at that time because I just couldn't see three-dimensionally. And so there were times that I would flap in and there just wasn't enough. And so in about 2008, I bought the Rona Galileos, to really look at joints. And I got that. I started using some of the implant planning software to help design guides for my surgeon or periodontist, and I started to really see some of the cases that were simpler, that had good attached tissue and plenty of bone, and so I started doing some of the surgeries again. So currently, probably I do maybe 30%, 35% of the implant placement myself, and I typically look for, after we determine tooth position, I look for good attached tissue and plenty of width and enough height and nothing scary that I'm going to hit, and I do those surgeries, and quite comfortably. You do it pretty much with surgical guides and often flapless in the right, indication. And so it's become a really fun part of what I do. And so again, the implant part of my practice has grown dramatically in the last 5 to 6 years for sure.
Yeah, I would have to agree with you. I tried some surgeries before cone beam, and I just found it to be a little more scary and stressful than I was wanting. And now that I'm using cone beam on a daily basis, it makes those surgeries that much more enjoyable and really takes a lot of the unknown and the stress out of it. And if treatment planned properly, I really enjoy those surgeries. But those main barriers, I think, are having access to cone beams, having the correct surgical and prosthetic training. I think those are the biggest factors keeping general dentists out is having the right training and having access to the CBCT or the cone beam. So the training part, obviously, your program at the Dawson Academy is a great foundation. But what other types of surgical trainings or courses are you aware of today that you would point dentists in if you knew of any?
But one of the ones that I visited not too long ago that was fairly impressive was the Engel Institute, which is in Charlotte. And I had a chance to go there, have a meeting with them, and it seemed like a a pretty solid basic training to learn the surgical aspects. First, single tooth, implant placement, recognizing sort of that sweet spot. They do some, I think second class, they do some grafting techniques, and third one is multiple implants. But what I like about it is they blend both lecture and some hands-on exercises with actually placing implants in people. So you actually, do some surgery on their patients, which I think is quite good. Obviously, niche is one of those gold standards out there that still chug along pretty good. And then, Pico's is available at a lot of levels, and over the years I've really admired Mike anytime I've gotten a chance to listen to him.
Yeah, no, I agree. There's definitely a lot of good courses out there, and different levels of hands-on and different levels of what they're doing. Are you involved with any integration academies?
I'm really not. I go to some of the meetings as guests. My plate is so full with so much of what I'm doing, and both the surgeon and the periodontist that I'm involved with go to between the perio meeting, the surgery meeting, and some of the integration meetings. They're always bringing back the latest content and information to keep me on that cutting edge. But I do think again, I think what a dentist has to really think about, and this is the tough part, is that I think I see young dentists, 28, 29, 30 years old, and they're drawn so heavily to learn how to place implants. And I would really counsel them that I think that's a good thing to learn, but just make sure that, as you've sort of alluded to, that in parallel they're learning pros and they're learning occlusion and they're learning treatment planning, because quite frankly anybody can learn to stick a screw into a bone, into the bone. It's just, how that thing is positioned, and not only directionally, but the emergence and the depth of the head of the implant, really understanding biologic width, how to shape tissue, and how teeth are different than implants. All those things factor into, whether you're ultimately going to be able to create, something that is going to have longevity and look good and be really indiscernible from a tooth. That's what's so amazing about where we are with dental implants now is, to be able to put something in that, will fool your dental hygienist. I mean, they'll be in there and won't be able to tell it's a dental implant. And that's really amazing compared to what we were doing back in the day with the basket Corvette implants. That was the first thing that I saw. Just had, abutments that were bent and all sorts of crazy stuff. It's gotten a lot better.
Yeah, it's definitely come a long way. I think I agree with you. I think everyone's jumping into surgery, but I think the restorative needs to be taught first. There's a lot with just how to restore implants correctly that is understated, and then also learning how to do site preparation, so learning how to extract teeth well and do good socket preservation. I tell people that's the first place to start your surgical training, is learn how to extract an unsavable tooth and prepare a socket.
Yeah, and create that Tonic Design or the Tonic Design. That I agree with you. I mean, that's where you totally can start to learn how pressure can influence the height of the pillows and how a flat root surface can actually allow that flat surface below the CJ can allow the tissues to create more coronally, and convex profiles cause tissues to recede. I agree with you. I mean, I learned so much about shaping soft tissues from Tonic Design that when it came time to really doing immediate load type cases and creating provisionals, really a provisional on an implant, it's just basically a socket tonic that happens to be connected to something. That's all it really is. So I love that analogy.
Seeing how to restore that space thinking with the end in mind, thinking with the emergence profile in mind, thinking with what kind of abutments you're going to use and what type of crown you're going to use before the implant's even placed, I think are critical factors. So that treatment planning component is a big deal.
And maybe recognizing that, if that central incisor's been gone a really long time and there's no papilla whatsoever, maybe an implant isn't the right restoration until you get some soft tissue there. Maybe you need to do some sort of augmentation of the soft tissue and then, do an implant or a fixed partial denture. Those are all options that you have to think about. I just still see way too many implants that have just been put in without any thought to, like you said, what the final restorations, what that end is going to be like. And it's supposed to be a prosthetically driven discipline, and I think sadly, a lot of times we're still far from that.
Yeah, it's easy to get hung up on the surgery, but then we have to remember patients don't want a screw in their jaw; they want a tooth in their mouth. So
yeah,
that's
a tooth
the whole.
A tooth that looks like a tooth.
Yeah, and that's why we're selling them on the implant over the bridge, because we're telling them this is going to work better, and so we have to keep that in mind. What do you like to do in the anterior zone if you've got a implant that's been placed in the best position? How are you restoring those in your practice with mindset of the cosmetic component?
Yeah, it's interesting. I was really trained initially on definitely on custom abutment type cement, retained type crown. So that's kind of what I was trained on. But more and more, and I think it's really a credit to really good guided surgery. I'm really doing more screw retained, and if I can get an implant in a precise position and I can get a nice screw retained restoration coming right out of the center of the cingulum, I like the screw retained option only because in the provisional phase, I can make a really nice provisional that's screw retained and allow for some time to develop the tissues. So by the time we get to the final restoration, I've got the tissue positioned where I want it, the pillows where I want it. We're really just duplicating that. So I think that's what you're asking me. I tend to like the type of design where I guess it's still a cement retained crown because it is cemented to the abutment outside of the mouth, but then the whole thing's screwed in. But I think that's definitely the trend now, and again, a lot of it is because of the periimplantitis issue that we're all reading about. But honestly, in hindsight, I did a lot of cement retained restorations on ankylosing implants in the anterior for a lot of years, and I was very careful in my cementation process, and thankfully really didn't see, still don't see those lasting. But I do think that the other thing that I do like about this retained option is that I think we've all seen a cement retained crown where the screw comes kind of loose and the crown's sort of wiggling in there, and you really don't have any way to get to it unless you destroy the crown. So I think with screw retained, I like the idea of being able to shape tissue in the provisional phase without worrying about provisionals coming loose, anything like that. And of course, in the permanent phase, something that's screw retained, retrievability is a big deal in my life. If I can just unscrew something or rescrew something, or it just makes it a very easy thing for me to deal with in my day if something happens.
Yeah, I agree completely. I think we used to all cement everything, and then now the literature is pushing towards screw retained, and with the surgical guides, it allows us to put the implants at the right angle so that screw retains is an option. And implant manufacturers are making different abutments and screws now to where access is more is better, and so we can do almost anything screw retained now. But in the instance where we can't, I still like to do maybe a titanium base with a zirconia top on the abutment and put that maybe 0.5 millimeters below the gum line and cement it there. Whereas If you just say, send the lab to the crown to lab and say, make crown, they're going to put that margin 5 millimeters deep, and you'll never clean that cement off.
Right. And that's, to me, where, particularly in the anterior, always going with the custom abutments. And we did a lot of Atlantis and things over the years. But, yeah, to me, the whole deal with the custom abutment is, like you say, getting the abutment to follow the contour of the tissue slightly subgingival. And I think that's why we had very little peri-implantitis. And you contrast that to some of the stock abutments that, that were really at the same height. I mean, they weren't at the same height of the implant, but they followed basically the flatness of the implant. So interproximally, your margins were way deep, and it just wasn't possible to get the cement out of there. And if you put too much cement in, you get a little hydrostatic pressure, then you're pushing the cement beyond that, and that's where I think some of the issues. So real care in getting the tissues healthy, and then having somebody that really understands abutment design. I think, even today, we occasionally run into, bimaxillary protrusive type patients where you really do have a lot of angulation in that maxillary area where you just can't get the implant without a lot of grafting. So to have a screw where it needs to be, even with some of these newer off-angle, screw access type things, it works out well to go the way we always did it with some sort of custom abutment, as you described, and cement retain. Still works.
Sure. What would you say are maybe your 3 best practices in implant dentistry? If there are 3 things that you do regarding implants that have made all the difference to you, what would those things be?
I think the first one is to not treatment plan it, to follow the same basic protocols that I would use in any sort of restorative case. And what I mean by that is I'm still going to get, my x-rays and probe the teeth and my photographs and my mounted models, and still think about both aesthetic and occlusal design. So I'm still going to go through those same basic parameters to figure out where the teeth need to be in space from aesthetic and functional perspective. And then the second thing is, once we've done that, really relate those positions to a really good cone beam, so that when I'm looking at the cone beam, I'm just not measuring, where the width and the height of the bone, but I'm going to be able to virtually place implants in a position where I can achieve my aesthetic and functional goal. So if I do the same the way I've always done it, and then added the cone beam, now I really plan. And then the third best practice is just don't place an implant without a really good guide. And I think the more guided we can go, the better. I think it's just, I hear all the time, well, my surgeon's done 90 million implants, so he doesn't really need a guide. But the more we do this, the more tenths of millimeters matter, and we're trying to get a result that's going to be optimal. So I think those are the 3 things. I think that if we follow those 3 things day in and day out, whether it's a simple case or all the way up to somebody losing their teeth and having a whole mouth implants placed, it sort of follows that general 3-part process. It again just worked out really well for me. What was kind of cool about that is that when we really jumped back on the bandwagon with implant dentistry, if you really know where teeth go, that's often the hardest part from a treatment perspective. But if you can figure that out, then you can really quickly start using the different softwares that are available to place the implants, and you're going to know quickly whether you got enough bone or not. And so that helps you determine whether you need to graft first or not. And the whole thing starts to become very, very predictive.
Sure. Yeah, and I think that's what everybody wants, is that level of predictability.
Oh, yeah. Absolutely.
So what would you say your goals are moving forward in implant dentistry? Or what are you interested or curious in learning more about? What's an area of implant dentistry you think, I want to get more involved with this, or get more training in this, or figure out more about such and such? What would that be?
I think that it sort of goes hand in hand with some of the other things we're working on right now. But I think, implant dentistry's really come a long way being able to do a lot of these things virtually in terms of virtual implant placement and all, and marrying our models with, the cone beam and all that. But I think what I really want to go to another level on is I would really like to get to a point where we can do the whole occlusal analysis all the way through digitally, so that all of our analysis from whether we're going to equilibrate or move teeth or do the restorative, that all that can be done in a virtual world, as well as our implant planning and all that as well. But I think that, right now, a lot of us sort of sit in that 1 foot in the analog world and 1 foot in that digital world. And sometimes it makes it a little bit more difficult to go from the articulator back to the cone beam and get a guide that is precise as it possibly can be. So, I'm spending a lot of my time working with the different companies and manufacturers, and I sit right next door to Bayview Dental Lab, who's spending a small fortune right now on all the scanners and softwares that are available to us. But at the Dawson Academy, that's one of the things that I think we really want to lead the way on, is for us to be able to look at a computer two-dimensionally with photographs and then have all of the bells and whistles from a three-dimensional perspective to be able to plan the whole thing, not only just where the implant goes, but all the way down to precisely how all the teeth will fit together with the final occlusion. And I think that if we can get to that, and as long as it doesn't cost $8 million, we can come up with a protocol that's affordable. What excites me about that is I think a lot more dentists would be more likely to do it. I think right now, having to take a face bow and mount models and centric relation and do the things that we ask them to do, as well as relate it back to the cone beam, it all becomes cumbersome and sometimes difficult. And so, a big part of my goal moving forward is to make all this easier to do, more accurate, and hopefully it'll become more mainstream.
Yeah, I think that's fantastic, because I think, there's some hang-ups, and it's time and money and training and technology and all the same things it's always been. But I feel like, we're just on the cusp of that next big leap. I mean, we've come so far, but, I'm still waiting to see the intraoral scanner marry to the models, which marries to the CBCT, where you can, like you said, design the whole case on that virtual model, and
something that's dynamic, something where you can actually see the excursive movements and see the occlusion and see the interferences and be able to reshape the tooth or move it or add to it. I mean, that's all the stuff we do now with stone. That's funny, but my daughter, she's a freshman at the University of Louisville right now, dental school, and she jokes with me all the time that I need to figure this out before she gets out of dental school, because she's not going to practice dentistry in the Stone Age, which is kind of a nice way to say it. But I do think you're right. I think there's so many, if you think about it, all the things that we want to do are available right now. It's just that it's not all infused into sort of one suite. It's, you can move teeth in the ortho software. We can, add the teeth with CERAC or reshapes. You can reshape teeth in Exocad. It's just all over the place. And we need to be able to have something where we're either doing it ourselves in our dental lab or have some tool that we can communicate seamlessly with a dental lab to do some of this design. But by and large, dentistry still today, we're still flying by the seat of our pants an awful lot. And I think that all what's happening right now, we're very close to having something that will radically change how we do things, and also make it much easier for, say, a dental student to understand at a very high level. Sure.
Yeah, because that's my other concern is, and this is a whole different topic, but I live in Kansas City, so we have a dental school, and I talked with a dental student last week, and they said, of course they don't get to place implants in dental school. And I think they're trying to get the requirements to where they at least have to restore one tooth, but it's tough because, the perio department wants to place them and the surgery department wants to place them. So there's an argument on which department gets to place the implants with the lack of patients they have. And then there's not enough cases for all the students to replace one. So the training is still needing to be there. And how do you integrate that in the dental school? But I think that technological gap, like you're saying, is putting all those pieces together and marrying all those technologies together in one precise fit that makes it all come together. I think when that happens, we're going to see a real major leap for our industry and as it relates to implants, but just all the treatment planning together. So that'll be really exciting.
That's what we're working on, and we want to be. That's one of the things that I think if we can have some input into that will be huge. And again, not only for implant dentistry, but for all the things that all the more complicated scenarios when we're changing where teeth are, we're changing how teeth occlude, whether we're just adjusting a bite or restoring a bite or orthodontic surgery. I mean, we should have all these disciplines still need better ways to predict the outcome before we actually do it. So it just makes sense that we should be doing this with powerful software and a computer rather than, with the inaccuracies that come with stone.
Sure. Okay, last question, then we'll wrap up here. Who else do you think would be at the top of your list that you think I should interview?
Certainly, my Picos. Picos is he's one of those guys. Craig Mish is somebody that I've listened to and have a lot of respect for. They both happen to be Florida people, but I'd probably say Craig Mish and Picos. And then let's see if there's anybody on the perio side. Probably Dennis Tarnow. Dennis is another one that I think has done a tremendous amount for us to advance our understanding of the shaping of tissue when we're dealing with two teeth next to each other, or a tooth and implant, or implant and implant. He profoundly helped me become more predictive with my tissue shaping. So those three guys, I think, are pretty tops to me.
Great. Yeah, I actually had Michael and Dennis on my list to try to get a hold of if I can get through their secretaries. But I'll add Craig also on my to-do list, and I'm going to try to do as many of these as I can and just kind of push this thing forward. But I really appreciate your time today.
No, my pleasure. Say hi to your dad for me. And when I saw that you called, I did a quick Google and saw that I said, this has got to be John's son. And so I saw your website. But anyway, I have a lot of respect for your pop. I'll tell him I said hello.
I will do. I know he likes you, and he wanted me to tell you hello. So okay. I'll owe you a couple beers next time I come to one of your events, and look forward to seeing you soon.
Sounds good.